Chapter 52, The Child with a Neurological Alteration. Increased cranial pressure, ICP, reflects the pressure exerted by the blood, brain, CSF, and any other space-occupying fluid or mass. Increased ICP results from a disturbance in the autoregulation and is defined as pressure sustained at 20 millimeters of mercury or higher for 5 minutes or longer. Please see box 52.1 for the differences and manifestations between the infant and the child. There are certain assessment areas you need to look at when you determine the neurologic condition of a child. First thing is their level of consciousness. The Glasgow Coma scale is used for both the infant and child. Your book has both scales listed, so please look at those. You must look at their behavior as well. Changes in the child's normal behavior pattern may be an important early sign of increased ICP. Parents often are the first ones that will notice a change in the child's behavior. Therefore, a parent's comment that he isn't acting like himself should be taken seriously. Irritability, mild confusion, and agitation are symptoms that warrant further assessment. As ICP rises, compression of the third cranial nerve occurs, resulting in pupil dilatation with sluggish or absent constriction and response to light. A fixed, dilated pupil is an ominous sign in an unconscious child. The child with an increased ICP exhibits changes in motor function. Purposeful movements will decrease and abnormal posturing may be observed. Temp elevation may occur in children with increased ICP. Cushing's response, which consists of an increased systolic blood pressure with widening pulse pressure, bradycardia, and a change in respiratory rate and pattern, is usually apparent just before or at the time of the brainstem herniation. As ICP rises, the child's baseline respiratory pattern may change, exhibiting Cheyenne-Stokes respirations, central neurogenic hyperventilation, or apneustic breathing. Diagnostic tests for increased ICP include CT, MRI, lumbar puncture, serum and urine electrolytes, arterial blood gas determinations, a CBC, EEG, and radiography. The management of increased ICP is directed towards treating its underlying cause, reducing the volume of the CSF, preserving cerebral metabolic function, and avoiding situations that will increase the ICP. An intraventricular catheter may be used to measure ICP, drain CSF, and/or administer medications. The head of the child's bed should be elevated 30 degrees with midline positioning of the head, and normothermia should be maintained. The child may be given an osmotic diuretic, for example mannitol, or hypertonic saline, sedation and analgesia, and anticonvulsant medications. Blood glucose levels are closely monitored to maintain normal levels and prevent further increase in metabolic demands. IV fluid boluses with normal saline are used in children with hypovolemia. Hyperventilation is used if there are signs of cerebral herniation. Spina bifida is a congenital neural tube defect known as NTD, characterized by incomplete closure of the vertebrae and neural tube during fetal development. Spina bifida is classified as spina bifida occulta and spina bifida cystica. Spina bifida occulta usually occurs between the L5 and S1 vertebrae with failure of the vertebrae to completely fuse. Some children with spina bifida occulta have no sensory or motor deficits. The only clinical manifestation may be a dimple or a tuft of hair, a hemangioma, or lymphoma in the lower lumbar of the sacral area, detected accidentally on routine radiographs. Spina bifida cystica is a more extensive defect with a range of sensory and motor impairments. In addition to the appearance of the lesions, manifestations relate to the degree of the deficit, which is determined by the level of the lesion. Children with spina bifida are at high risk for developing latex allergies because of the frequent exposure to latex during catheterizations, shunt placements, and other operations. Diagnostic tests include determining the alpha-fetoprotein, the AFP level, in the blood at 16 to 18 weeks of gestation. If the AFP screen is elevated, an amniocentesis and fetal ultrasound are performed. After delivery, the infant may undergo a CT scan or myelography. Prenatal microsurgical closure of the myelogenous performed at approximately 19 to 25 weeks of gestation may reduce some complications that can occur in the infant. There are risks to the surgery as well. Following birth, immediate surgical closure of the defect decreases the risk of infection, morbidity, and mortality. Other benefits are improved prognosis without further cord deterioration and earlier and easier physical handling and bonding between the newborn and the parents. The child is best managed in a multi-specialty outpatient setting. Urodynamic studies are performed early and a bladder emptying program is initiated with close monitoring of the child's urinary tract infection status. In most incidents, the child will require orthopedic bracing and possibly orthopedic surgery to maximize the child's mobility. Spina bifida clinics that coordinate care between the multiple providers to implement the plan of care for a patient in one visit have fewer complications and hospitalizations of patients and improved communication between the providers and the patient and their family. Hydrocephalus develops as a result of an imbalance between the production and the absorption of CSF. An excess CSF accumulates in the ventricular system. The ventriculars become dilated and the brain is compressed against the skull. This results in enlargement of the skull if the sutures are open. It results in signs and symptoms of increased ICP if the sutures are fused. Hydrocephalus may be congenital, acquired, or of unknown etiology. In infancy, hydrocephalus is most often congenital or related to prematurity. Anatomic differences between infants and children, manifestations of hydrocephalus differ according to that developmental stage, so please see Table 52.2 for these differences. Diagnostic tests for hydrocephalus include serial measurements of the head circumference, CT, MRI, ultrasound, and lumbar puncture with pressure monitoring. Therapy is aimed at preventing further CSF accumulation and reducing disability and death. The objective is to bypass the blockage and drain the fluid from the ventricles to an area where it can be reabsorbed into circulation. A ventricular peritoneal shunt, which is a tube leading from the ventricles out of the skull and passing under the skin to the peritoneal cavity, accomplishes this goal. An alternate shunt, the ventriculateral shunt, which is used in older children, drains the fluid from the ventricles to the right atrium of the heart. Infection and shunt malformations are common occurrences after the shunt is placed, so monitoring for signs of a fever and explaining this to parents is a priority. The shunt may need to be revised as the child grows and lifelong monitoring is necessary. Cerebral palsy is a chronic, non-progressive disorder of posture and movement. It's characterized by difficulty in controlling the muscles because of an abnormality in the extrapyramidal or pyramidal motor system, which includes your motor cortex, your basal ganglia, and the cerebellum. Comorbidities such as cognitive, hearing, speech, and visual impairments, as well as seizures, are common but vary widely from one affected child to another. Box 52.3 lists factors related to cerebral palsy. Many times the cause is from something that happened prenatally or during the birth process. The cause potentially in many times is trauma of some form. Shaken baby syndrome is one cause. Manifestations vary greatly due to the severity. It can be something as simple as a minor issue with their gait, but to more extreme muscle spasticity and unable to take any food by mouth. A diagnostic evaluation includes EEG, CT, or MRI, electrolyte levels, metabolic workup, a thorough history, and complete neurologic examination. The goal of managing the child with CP is early recognition and intervention to maximize the child's abilities. The child might be intellectually intact, but this factor can be overlooked because of the child's physical limitations. Intrathecal baclofen, a skeletal muscle relaxant administered via an infusion pump, can be used to treat severe spasticity in children with CP. Benzos are also given to treat spasticity. Close monitoring of the child for infection and the pump for malfunction, as well as correct pump assembly and programming, are required. A multidisciplinary healthcare team approach is necessary to meet the many needs of the child with CP. The team includes the child and the family, pediatrician, neurologist, orthopedic surgeon, nurse, speech and hearing therapist, social worker, occupational therapist, physical therapist, educators, psychiatrist, neurosurgeon, and orthotist. A few of the most common types of head injuries include closed head injuries, open head injury, coup injury, which is a cerebral injury sustained directly below the site of impact, and counter coup injury, which is a cerebral injury sustained in the region or pole opposite the site of impact, which is caused by rapid movement of the semi-solid brain within the cranial vault. This type of injury occurs when shaken baby syndrome and also in car accidents. Head injuries include anything from skull fractures to a simple laceration. Concussions are common finding in the pediatric population. Head injuries are classified as minor, moderate, or severe as correlated with the GCS. Children with minor head injuries score 13 or higher with the GCS and can have a change in the level of consciousness and also exhibit transient periods of confusion, irritability, vomiting, somnolence, and headache. Moderate scores are head injury scores between 9 and 12 and severe injury scores less than 8. Moderate to severe head injuries are marked by decreased level of consciousness, changes in vital signs, signs of increased ICP. They can have retinal hemorrhage, hemiparesis, and pallidemia. Seizures may occur within the first 7 days after a moderate to severe head injury. Diagnostic evaluation includes a complete history of the event, helps to determine the mechanism of injury and whether the child lost consciousness. Spinal x-rays need to rule out any spinal injury. A neuro exam needs to be done, and looking for signs of ICP, CT, and MRIs are the main tests that they will do next. Initial management of the child with a head injury includes assessment of the airway, ventilatory function, neurological status, and any other injuries. Interventions to uphold vital functions include adequate oxygenation and perfusion are provided until all injuries are determined. The goal of treatment is to minimize long-term sequelae injuries are determined. The increased ICP or seizures can develop in a child with head injury. The child with a TBI, the presence of hypoventilation, hypoxemia, and hypotension is concerning and correlates with increased mortality. Management and nursing considerations will depend on what type of injury has occurred. With concussions, children are at risk for long-term complications that necessitate appropriate management. Most patients have an increase in symptom severity when returning to school in the first 2 weeks after a concussion. Therefore, a recommendation to stay home from school for 1 to 3 days or until the child can tolerate 30 minutes of cognitive activity without an increase in symptoms is beneficial. Recovery occurs more quickly in those who rest immediately after the injury. This is exactly what they need to do. Under no circumstances should a child or adolescent resume playing a sports the same day as a concussion. Protocols have been developed to guide the gradual return of the young athlete to return to play after concussion. Nursing considerations for head injuries in general include initial and ongoing assessment of the child with a head injury, which includes the evaluation of ABCDEs, which are airway, breathing, circulation, disability, which means their level of consciousness, and exposure. The nurse must closely monitor for signs and symptoms of increased pressure, as well as to avoid activities and stimuli that can increase your ICP. Positioning with the head of the bed elevated 30 to 45 degrees promotes venous drainage. Any child with a head injury needs to be assessed for fluid and electrolyte alterations. If the child is discharged from the emergency department, written instructions should be given to parents for home monitoring, signs and symptoms to be immediately reported to the physician, and follow-up care. Manifestations of spinal cord injury include loss of some or all movement or sensation below the level of injury, respiratory depression or apnea, hypotension and bradycardia, hypothermia, and neck pain. These signs vary with the level of injury as well as whether the spinal cord injury is complete or incomplete. If complete, the cord is completely severed and no spinal intervention is present below the injury. After the nurse takes the history of the injury and performs a complete neurological examination, the extent of the spinal cord injury is determined by radiography or MRI. Current treatment of spinal cord injuries include immobilization and steroid therapy. If used, steroids must be administered within 8 hours of the injury as a bolus of 30 milligrams per kilogram, followed by a continuous infusion of 5.4 milligrams per kilogram per hour for 23 hours. Because of adverse effects associated with steroid administration, use of steroids is controversial. More research is needed to evaluate the effectiveness of steroid therapy for cervical spine injuries and to determine protocols for steroid administration time after the spinal injury. Until permanent surgical stabilization can be formed, other treatments such as halo traction and Gardner-Well tongs might be used for temporary stabilization. Autonomic dysreflexia, or AD, is characterized by severe peripheral hypertension. AD can occur in children following spinal cord injuries at or above T6 level. Early signs include sudden, significant rise in systolic and diastolic blood pressure, usually with bradycardia. They'll have flushing of the face, neck, and shoulders. They'll have goosebumps above the TE, or T6. Blurred vision, spots in the child's visual field, and nasal congestion. Recognition of these signs followed by emergency treatment to lower the blood pressure is essential to prevent cerebral and retinal hemorrhage, seizures, and myocardial infarction. The spine must be immobilized before any attempt is made to move the child. The airway is assessed immediately, and if intubation is necessary, it is done without hyperextending the neck. Circulation is then assessed. Hypotension can result from either hypovolemia or neurogenic shock. Bradycardia and hyperthermia may occur. The nurse closely monitors the child's body temp and oxygenation status. The neurological assessment by the nurse includes evaluating mobility, sensation, and reflexes. The nurse considers the suspected level of spinal cord injury and whether the injury is thought to be complete or incomplete. The neurological assessment is ongoing and carefully documented so that changes can be promptly reported. The child is also assessed for other areas of trauma and the impact of the spinal cord injury on other systems, including the GU, GI, and integumentary. You have learned about seizures before, so this will be a brief overview. Please refer back to your adult health book if you need more information. Tonic-clonic seizures can cause an abrupt arrest of activity and impairment of consciousness. The tonic phase consists of sustained, generalized stiffening of the muscles, including the diaphragm, lasting a few seconds. The clonic phase is systemic and rhythmic, consisting of alternating contraction and relaxation of major muscle groups. This phase usually ends spontaneous in less than 5 minutes. Atonic seizures can cause an abrupt loss of postural tone, impairment of consciousness, confusion, lethargy, and sleep. A child may have multiple episodes of sudden and brief head drop or a drop attack during which they fall to the ground, often face down, lose consciousness for a few seconds, and then get back up if nothing happened. Myoclonic seizures are brief random contractions of muscle group, followed by the loss of muscle tone and forward falling. Formerly called petit mal seizures, absent seizures are very brief episodes of altered consciousness. Typically, no muscle activity occurs except for upward rolling of the eyes. The child has a blank facial expression. Absent seizures last only 5 to 20 seconds or less, but they can occur up to hundreds of times per day. Focal seizures are described according to the features exhibited by the child during the seizure. Types of features are awareness responsive, which can be altered or intact. There can be sensory or psychic, which they have an aura, motor or autonomic. Impairments in conscious or awareness and decreased responsiveness occur with some but not all focal seizures. An aura, which is the sensation of upcoming seizure, is actually part of a focal seizure. Other sensory symptoms include rising abdominal feeling, an unexplained sense of fear, a déjà vu feeling, an odd taste in the mouth or odd smell, and visual or auditory hallucinations. Febrile seizures are generally seen in young children between ages of 6 months and 3 years, with a peak of incidence of 18 months. Febrile seizures occur more frequently in males and in those with a familial history. The height and rapidity of temperature elevation seems to be the factor in precipitating febrile seizures. The temp is usually elevated above 102. The seizure activity occurs during the temperature rise rather than after a prolonged elevation. So usually it's in the first 24 hours of the illness. A thorough description of the child's behavior before, during, and after the seizure activity is important to delineate the type of seizure. Video recording and EEG monitoring to help identify the seizures. Both CT and MRI will indicate trauma, tumor, or congenital malformation. The basic principle of treatment for the child with seizure is to treat the whole child. Anti-epileptic medications are commonly used to manage seizures. Treatment goals are to identify and correct the cause of seizures, eliminate the seizures with a minimum of side effects and the least amount of medication, and normalize the lives of the child and the family. A ketogenic diet is another treatment option for children with epilepsy. The diet is essentially carb-free, composed mostly of fats, and produces a state of ketosis that is thought to control seizures through an anti-epileptic effects of ketone bodies on the brain. Status epilepticus is a medical emergency. It is marked by prolonged seizure activity in the form of either a single seizure lasting 5 minutes or more, or recurrent seizures lasting more than 5 minutes with no return to normal level of consciousness between seizures. Treatment consists of maintaining optimal respiratory and hemodynamic function and identifying and treating the cause of seizure activity. Diazepam, lorazepam, or Midalzem is given IV. If IV access cannot be obtained, medications can be given orally or rectally. Phosphate or phenobarbital may be given IV as a second round of drugs if diazepam or lorazepam does not stop the seizures. The intramuscular route is not used because absorption of the medication is unpredictable. Meningitis is the most common infectious process affecting the CNS. It can occur as primary disease or a result of complications or neurosurgery, trauma, systemic infection, or sinus or ear infection. A wide variety of bacteria and viruses can be responsible for the primary infection. Early diagnosis and prompt antibiotic therapy reduce mortality rates, which remain high, and the incidence of complications from bacterial meningitis. Signs and symptoms of meningitis vary according to the stage of the child and the duration of the preceding illness. No single hallmark sign or symptom exists. The clinical signs of meningitis in the neonate include poor feeding, poor sucking, vomiting, diarrhea, poor muscle tone, weak cry, hypothermia or hyperthermia, apnea, seizures, sepsis, DIC, a full, tense, and bulging fontanelle, and lethargy. Clinical signs of meningitis in infant and preschool children include fever, poor feeding, vomiting, irritability, seizures, a high-pitched cry, bulging anterior fontanelle, and lethargy. Early clinical signs of meningitis in children and adolescents include severe headache, photophobia, nuchal rigidity, fever, altered level of consciousness, decreased appetite, vomiting, diarrhea, agitation, and drowsiness. Kierkegaard sign, which is pain with extension of the leg and knee, and Brodinski sign, which is a flexion of the head causing flexion of the hips and knees, are often exhibited. In the case of meningococcal infection, a petechial or purpuric rash may be observed. Late signs include a decreased level of consciousness and seizures. The diagnosis made by testing CSF, obtained by lumbar puncture. Findings usually include increased CSF pressure, cloudy CSF in the case of bacterial meningitis, high protein concentration, and low glucose level. Blood cultures are obtained. Nose and throat cultures may be done, particularly if the CSF culture is negative. Acute bacterial meningitis is a medical emergency requiring early recognition and prompt, aggressive management to avoid adverse outcome. The child is placed in a private room on droplet transmission precautions, and these are maintained for at least 24 hours after antibiotics are initiated. Immediate initiation and uninterrupted IV administration of the appropriate antibiotics are essential in cases of suspected bacterial meningitis. A delay could be fatal. Morbidity and mortality associated with bacterial meningitis is reduced by adjunctive treatment with dexamethasone, which can decrease intracranial pressure. Headaches are a common disorder in children of all ages. Headaches are common disorders in children and their prevalence has significantly increased in the Western countries and in Asia over the last 30 years. Up to 75% of children and adolescents complain of occasional headaches, with 20% of these children affected by chronic tension and migraine headaches. The three primary sources of recurrent headaches are vascular, tension, and increased ICP. Vascular headaches include migraines and headaches that occur as a result of arteriovenous malfunctions. Tension headaches frequently are the result of stress. Contributing factors to increased ICP are space-occupying lesions and hydrocephalus. Manifestations of migraines range from mild episodes in which a child can continue with daily activities to episodes that force a child to be quiet in a dark room for relief. In some cases, an aura occurs before the headache begins. Once the headache begins, the most common symptoms include throbbing pain, often on both sides of the head, nausea and vomiting, irritability, abdominal pain, photophobia, and phonophobia. The pain of typical migraine lasts from 1 hour to more than 48 hours. Depression and anxiety frequently coexist with migraines. The pain associated with tension-type headaches is usually more generalized than that of a migraine. The child may describe the pain as a band-like tightness or pressure, tight neck muscles, or soreness from the scalp. Nausea is rare, but fatigue and dizziness are common. These headaches can last for days or weeks, but usually do not interfere with the child's regular activities. Diagnostic evaluations is by symptoms, physical assessment, vitals, head circumference, and a thorough neuro exam, and CT or MRI may be done. The nurse educates the family and child about the factors that can trigger the onset of headaches, which can be stress, food, menstruation, visual stimuli, fatigue, certain medications, and how to make lifestyle changes that will lower stress and avoid triggers. Keeping a diary of the child's headaches and pre-headache events will help identify specific triggers. Electronic diaries are increasingly common for children 8 years and older. Acute management includes placing the child in a dark, quiet environment and administering medication. Long-term medication management focuses on education about and elimination of the triggers, stress relief measures, and medication administration. Teaching adolescents stress reduction and relaxation techniques can alleviate symptoms, thereby decreasing the social isolation that often accompanies these headaches.